Hello everyone, welcome to today's lesson with Caleb Mlonga. So today we're going to look at ART, popularly known as ART, but it is called antiretroviral therapy. So in our previous videos, we have looked at HIV cycle, and we've also looked at the goals for ART. So here we're going to look at the several classes that are found in HIV or in antiretroviral therapy. So in the modern society, we use a combined antiretroviral therapy, which contains 3 drugs from at least 2 classes or 2 groups of ART. So here this drug has 3 drugs in it from 2 different classes. So this drug helps to reduce the amount of HIV in the body. It also helps to prevent HIV resistance to ART or treatment. It also helps to prevent death or optimistic infection, and it also decreases hospitalization in HIV positive patients. So not only that, but it also helps in the suppression of the virus in the body, but does not cure HIV. So therefore, I would go and check out the 2 videos that we have put out for HIV if you've not yet checked them out. So from there now, we're going to look at the classes of ART. So here are the 4 classes that we have in Zambia that are currently have been approved in Zambia. So we can see them. So we're going to start with, so we're going to look at our first drug, which is the nucleoside or nucleotide reverse transcriptase inhibitor. Some of the drugs that are found there is sidovidine, lamivudine, abacavir, tenofovir, and intracitabyne. So these are the drugs that are found there. So as we can see from the diagram and from the name, just you find that this drug prevents the conversion of HIV RNA to HIV DNA once it enters the cell. So if you've not yet checked out the life cycle of HIV, go and check out in the previous videos. The link will be in the description. So you find that HIV, when it enters the body, the virus enters the cell, you find that HIV, single-stranded HIV RNA has to be converted to single-stranded HIV DNA with the help of reverse transcriptase. But what will happen here is that this drug, the nucleoside reverse transcriptase inhibitor, will prevent the single-stranded HIV RNA to be converted to single-stranded HIV DNA by inhibiting the enzyme reverse transcriptase. So that's how this drug helps to prevent the multiplication of HIV. It is its mode of action. The second group of the ART drugs is the non-nucleoside reverse transcriptase inhibitor. And these drugs, some of the examples of the drug is nevirapine and efavirenz. These are the 2 most common drugs found in Zambia. So from there now we can look at their mode of action. So this is not very different from the first one, which is the nucleoside reverse transcriptase. But here, this drug does not involve with the nucleoside, which is it does not get involved with the HIV RNA, which is the nucleoside here. It just specifically blocks the reverse transcriptase. So here is the non-nucleoside reverse transcriptase inhibitor. So it does not involve itself with the HIV RNA, but it directly blocks the reverse transcriptase, which is the enzyme that is used to convert HIV RNA to HIV DNA. So this is the second group or class of ART drugs. So the difference between the two drugs that we can find is that the nucleoside reverse transcriptase inhibitor, this contains 40 versions of building blocks, the nucleotide used by the reverse transcriptase to convert RNA to DNA. So it has some material in it, some versions of the nucleotide that it blocks. It blocks the building blocks in the nucleotide that are used to convert RNA to DNA. When reverse transcriptase uses these 40 building blocks, the new DNA cannot be built correctly. So the reverse transcriptase inhibitors, they have a version of their own building blocks, the nucleotides that are used in the reverse transcriptase. So once these building blocks are used by the cell or by the HIV reverse transcriptase enzyme, it will make a 40 DNA or a DNA that is not built up correctly. Therefore, that DNA cannot be used to multiply and form new genomes or new virons. Then the second one is the one that we're talking about. The other one is the non-nucleotide reverse transcriptase inhibitor. So the non-nucleotide reverse transcriptase inhibitors, they inhibit viral DNA synthesis by attaching itself directly to the reverse transcriptase enzyme and thereby preventing it from converting RNA to DNA. So these non-nucleotide reverse transcriptase inhibitors, they bind to the reverse transcriptase, the reverse transcriptase enzyme, and prevent it from converting RNA to DNA. So the main difference here is that in NRTI, which is the nucleotide reverse transcriptase inhibitors, the drug has 40 building blocks that will go and disrupt the function of the reverse transcriptase to make a 40 or to build a DNA that is not properly built or that cannot properly function. Therefore, it will not go anywhere. While the non-reverse transcriptase, non-nucleotide reverse transcriptase inhibitors will bind directly to the reverse transcriptase and prevent it from converting RNA to DNA. So we can now look at our third group, which is the integrase inhibitor. Integrase inhibitor. And one of the most common drugs, the two common drugs that we find here is the rituximab and rituximab. So these are the most common drugs that we find, but the most common maybe that other people can have seen is the rituximab. So here, as we can see already, in this class of drugs, it prevents the integrase. So as we can see here from the diagram, the integrase enzyme is the one that helps the conversion, the integration of the double-stranded HIV DNA genome into the human DNA so that they can make one full set of DNA, which is the genome. So this integrase is the enzyme that helps to insert the DNA, the HIV DNA in the human DNA. Therefore, this drug prevents this enzyme from helping the HIV DNA to integrate or to insert it into the human genome. So this is the function of the third class of ART. So the final group that we're going to look at is a protease inhibitor, or PIs. So here in this class, we have examples such as propanova, ritonova, also have the atazanova, ritonova. We also have ritonova as the drugs that are most common. So from this class of drugs, of the ART drugs, will help by inhibiting the function of the protease inhibitors, which is to ensure that the HIV cells develop and mature. Therefore, this drug will prevent the function of the protease enzyme. So those are the 4 groups of drugs that are currently used in Zambia. So having looked at the 4 classes of drugs and their mode of action, now we're going to look at the drugs to be specific under those classes. So we'll start with the first class, which is the nucleoside reverse transcriptase inhibitor. So under the nucleoside reverse transcriptase inhibitor, we have the first drug, which is abacavir. So we have the first class, which is abacavir, which is abbreviated as ABC. So here, this drug is mostly the presentation is 300 milligrams. So there you find that it is administered to, the dosage of 300 is to children that are less than 37.5 kg. We give 8 milligrams per kg BD, but in adults we give 300 milligrams BD of this drug. So under elimination, you find that this drug, the only thing that we have to understand is that no adjustment for renal failure. So in renal failure, this drug is not contraindicated. So we are saying abacavir is the first class that we are looking at, and it has no contraindications in renal failure. So on the same abacavir, you find that the interaction is that we should not use it with TDF. So the TDF is the tenofovir. We should not use it with tenofovir. So popular side effects that we find, we have mild nausea, we have hypersensitivity as some of the most common drugs that we find. So under interactions, so this drug should not be used with tenofovir because they interact. So from there, now we're going to look at the side effects and the toxicity. So under the side effects, you find that this drug is well tolerated, but it has side effects such as mild nausea, hypersensitivity in most people, and it should not be given to infants less than 3 months. It should not be given to infants less than 3 months. So that's basically it about this drug. So we're going to look at another drug, which is lamivudine. So lamivudine is abbreviated as 3TC. It falls under the same class, which is the nucleotide reverse transcriptase inhibitor. The presentation is 150 milligrams in tablets and 10 milligrams per meal as a syrup. So under dosage, you find that children under 1 month can prescribe 2 milligrams per kg body weight, BD, which is twice a day. For children over 1 month up to 37 kg, they should be given 4 milligrams per kg body weight twice a day. And for children above 37.5 kg and for all adults, we can give 150 milligrams BD, which is twice a day. So this drug should be adjusted in renal impairment, which means in people with HIV that have renal conditions, we should adjust this drug downwards. So this drug does not have any known interaction with any other drug. Then on the side effects and toxicity, we find that this drug is well tolerated and it is also used in hepatitis B. So that's what we can talk about lamivudine. Then we look at another drug under the same group, which is tenofovir. So tenofovir is abbreviated as TDF. So TDF, the presentation is 300 milligrams, 200 milligrams, or 150, which means it can be presented in either of the three: 200 milligrams, 300 milligrams, or 150 milligram per tablet. So this drug is given there. So for children above 30 kg and for all adults, they have to be given 300 milligrams OD. And it is only approved for children who are above 10 years. So this drug has a specific contraindication with people with renal impairment. Therefore, this drug cannot be given in people with renal impairment. So avoid in renal impairment. Then under the same drug, it should not be used with a back cover. This drug has an drug interaction with a back cover, therefore it should not be used. Then we look at the side effects and toxicity. So this drug is well tolerated, but it has renal toxicity. Therefore, we should not use it in renal failure. And loss of bone mineral density. There's loss of bone mineral density when a patient is using this drug. Then furthermore, we have to assess the renal function, such as urinalysis and creatinine clearance, when the patient is prescribed this drug. Firstly, we have to check if this patient has a good renal function. So that is what we can talk about when we talk about tenofovir. Those are the things that we can highlight. And lastly, we'll look at the another drug, which is zidovudine. So zidovudine is abbreviated as ZDV or AZD. So under zidovudine, we have presentations such as 300 milligrams in tablets, 100 milligram capsules, or 10 milligrams per meal of syrup. So here you find that this is one of the drugs that is commonly used in Zambia, and it is mostly used in children that are less than 4 weeks, and it can be given at a dosage of 4 milligrams per kg body weight twice a day. And then for children between 4 weeks to 12 years, we can give 180 to 240 milligrams per day, twice a day. And then for children above 12 years and for all adults, we can give 300 milligrams BD. So those are the dosages for zidovudine. And then on elimination, how can it be eliminated? So in hepatic metabolism and renal elimination. So it should be adjusted in renal failure and do not use in severe hepatic impairment. So this drug should be adjusted in renal impairment and should not be used in severe hepatic impairment. So still on zidovudine, it should not be used with D4T drug because of its interaction. Then we look at the side effects. So the side effects and toxicity, it is well tolerated in children, but it has common side effects such as bone marrow suppression, anemia, GIT intolerance, headache, dark fingernails. Those are the most common side effects that we can find. And the uncommon ones, we have lactic acidosis as one of them. So this is one of the drug, and these are the most common side effects that we can find. So we have looked at the several drugs that are found under the nucleotide reverse transcriptase inhibitors. Therefore, we will now move to the next group of drugs. So look at another drug, which is the non-nucleoside reverse transcriptase inhibitor, the NNRTI. So the first drug that we're going to look at is ephedrine, which is abbreviated as EFV. So this drug is not effective in HIV type 2. It is not effective in HIV type 2. Under the presentations, we have it can be presented in capsules, which is 200 milligrams or 400 milligrams and 600 milligrams tablets. So these are the presentations. Then now we can look at the dosage. So under the dosage, you find that we can give it to children more than 3 months or more or equal to 10 kg body weight. So for pediatric doses, refer to the table in the manual. So we are going to see one of the tables that we have in the manual here. So under ephedrine, you'll find that it can be given at 14 milligrams per day, OD, once a day. So in adults and adolescents between 12 to 19 years, we can give 400 milligrams OD per oral. And then for adults and adolescents between 10 to 12 years on TB treatment, or pregnant and or breastfeeding women, we can give 600 milligrams OD per oral. So this simply means for those children or for those adolescents and adults who have been on TB treatment for 10 to 12 years, we can give 600 milligrams per oral OD. Or for those breastfeeding or pregnant women, we can give it at 600 milligrams per oral. And then on elimination, we're saying it has a strong half-life. Therefore, it has hepatic P450 metabolism which is now just talking about a strong half-life. Therefore, it cannot be eliminated as fast from the body. So still on the same drug, we're saying it has an interaction with rifampicin, which is a drug for TB treatment. Therefore, rifampicin reduces equivalence levels by 30%, but use standardized dose for equivalence. So we are saying for those people who have on those who have been using the TB drugs for 10 to 15 years, we have to give 600 milligrams per day, which is OD. And then from there, now we're going to look at the side effects and toxicity. So we have CNS effects such as sleepiness, strange dreams, usually resolve after weeks to months of rash. Under the same drug, you find that it is also used in a pregnant women at any period during their pregnancy. So from there, you understand that this drug in Zambia today has been restricted because of its side effects that are severe, and it has been mostly withdrawn in most facilities because of its side effects such as sleepiness and other strange dreams. So this drug is not currently used as it was, but it is still on the market. So from there, we look at another drug, which is nevirapine. So nevirapine is abbreviated as NVP. It is abbreviated as NVP. It is not also effective for HIV type 2. So under presentation, nevirapine can be in tablets, which is 200 milligrams. For the dosage, for prophylaxis, this nevirapine can be given at 4 to 5 kg per body weight once a day. For induction, it can be given at 10 milligrams per kg body weight, OD for 14 days, then BD, or 120 to 200 milligrams OD for 14 days, then BD. But in adults, we find that it is given at 200 milligrams OD for 14 days, then BD. So when we talk about prophylaxis, we are meaning before exposure. So prophylaxis is a treatment that is so there are two types of prophylaxis. We have a post-exposure prophylaxis and the pre-exposure prophylaxis. So prophylaxis is the treatment of the drug, the virus, before it has basically become, before it actually infects the cells. So therefore, prophylaxis will help treat this HIV virus before it enters the cell, and that will enable that person to be free from the virus. That is what we're talking about when we say prophylaxis. So nevirapine must be given OD for first 2 weeks. So nevirapine has to be given OD for the first 2 weeks. Under elimination was saying that it also has a long half-life. That means it can take quite a long time to be eliminated out of the body. Then under interaction, we're saying rifampicin lowers NVP, which is nevirapine, by 37 to 50%, of this drug. Therefore, they should not be used together. So nevirapine should not be used together with rifampicin. Then the common side effects that we so under side effects and toxicity, we have rash. We also have signs of Stevens-Johnson, which if they present, a person should be stopped from taking this drug. We also have hepatitis that can be severe and should be avoided with CD4 count, with a low CD4, with a high CD4 count. So still on nevirapine, we're going to look at the elimination. So of which we're saying it has a strong and long half-life. Therefore, it cannot be excreted or eliminated out of the body easily. So under interaction, we're saying it should not be used together with rifampicin because rifampicin reduces its level to 37 to 58%. And then under side effects and toxicity, we're saying the common side effects is rash, signs of Stevens-Johnson, which when they present, the patient should be stopped from taking the drug. And then we also have hepatitis. So it should not be given in hepatitis, especially it should be avoided. So we are also talking about the second toxicity that it has is hepatotoxicity, more frequently in women than in men, and more likely to be seen in antiretroviral naive women with high CD4 count of above 250 cells per millimeter, and for men, more than 400 cells per millimeter. So we're saying this drug has toxicity effects of hepatotoxicity, which is commonly seen in women with a high CD4 count. And then it is a risk in children and is not well described. So the risk in children is not well described. So having that in mind, we have looked at the second drug under this class, which is nevirapine. So now we can look at the third group of the third class of ART, which is protease inhibitors, popularly known as or abbreviated as PIs. So the first drug that we are going to look at is ropinavir ritonavir. So it is abbreviated as LPVR. So this drug under the presentation was saying it is a combination of two drugs. It is a combination of two drugs. So it has 100 milligrams of ropinavir and 25 milligrams of ritonavir. Or it can also be presented in tablets as 200 milligrams ropinavir and 50 milligrams ritonavir. So under the dosage, you should take it with food. But for tablets, we are saying we can take with or without food. So for the capsules, you take them with food, and for the tablets, you take them with or without food. So under the dosage, we are saying for children above 1 month, we give 230 to 300 milligrams BD, and that is the highest dose for younger children. So it should be avoided in children or in a child below 14 days. So this is, we're saying for children above 1 month, we have to give 230 to 300 milligrams. Then for adults, we're saying we're going to give 400 milligrams of rupinovir ritonavir BD, which is 400 plus 100 milligrams of rupinovir. So under the side effect, under the elimination, before we look at the side effects, it has the half-life. So meaning it can take some time to be eliminated from the body. And then we look at the interaction, we're saying it interacts with rifampicin, which lowers its level to a quarter. Therefore, you should super boost LPV, which is rupinovir, to a ratio of 1:1 as required. Therefore, we are saying this rifampicin will lower the dosage of ritonavir, rupinovir ritonavir. Therefore, they should be super boosted to make a ratio of 1:1. And then we look at the side effects and toxicity. So the side effects, the common side effects that we have is nausea, vomiting, and diarrhea. And then the class effects include cholesterol increases and insulin resistance. So here's some of the toxic effects of this drug is that it increases the amount of cholesterol in the body and increases insulin resistance. So that is what we can talk about when we look at rupinovir ritonavir. So here we're looking at our last class of drugs, which is the integrase inhibitor. And under the integrase inhibitor, we're going to look at our first drug, which is the raltegravir. So it is abbreviated as RAL or RAL. So this drug is presented in pediatrics. We give 100. It is presented to be 100 milligrams in tablets, and in adults it's 400 milligrams in tablets. Under storage, we find that this drug under storage, it should be stored at room temperature. And then we look at the dosage. So under the dosage, we are saying pediatrics, meaning in children, we can give based on their weight. We can give based on their weight. Then in adults, we're saying 400 milligrams BD dosing. So in adults, we give 400 milligrams twice a day. And then we say we move to the next drug. We move to the next drug, which is the raltegravir. So this one is abbreviated as DTG. So this one is not mostly given in children, but the presentation in adult is 50 milligrams. It is 50 milligrams. But when it is given in children or in pediatrics, we give according to the weight. And then for adults, we're saying 50 milligrams OD per day, which is once a day. So it is approved in children over 12 years and 40 kg. So this drug is only approved in children who are over 12 years and 40 kg and in adults. And it does not have any food restrictions. So under the same drug, we're saying, so from there now we can look at the interactions of this drug. So we're saying raltegravir can be used with rifampicin, but it should be doubled. The dose has to be doubled, which is 50 milligrams BD instead of OD. And then it should be used 2 hours before or 6 hours after the use of these drugs that are listed below, which we have magnesium or aluminum containing antacids, calcium, iron supplements, and multivitamins, because these drugs interact with titographer. Then when we look at the side effects and toxicity, we are saying it has very few side effects, but the common ones that we have is diarrhea, insomnia, and nasopharyngitis as the most common side effects.
Yes, so we have come to the end of our lesson. Thank you for being with us. Kindly comment, like, and share our video. So for those with any questions, you can leave your questions in the comment section. Thank you for attending our lesson. God bless you. See you next time.